Good afternoon, everyone. Thank you all for joining us on today's webinar, where we'll discuss key takeaways of the CARES Act, including key provisions from recently enacted legislation and regulatory changes related to COVID-19 that your healthcare organization can benefit from. We have 15 minutes at the end of the presentation for Q&A. Feel free to send your questions along as they come to you, and we will address as many of them as we can at the end of the presentation. Now, Erin Cohen, Principal and Healthcare Co-Practice Leader with Citron Cooperman, will kick off today's discussion. Erin?
Thanks. We really appreciate everybody being on the webinar. Obviously, these are unprecedented times that we're in right now, and the pace of legislative and regulatory changes it's really dizzying. So what we've really attempted to do here is to provide as up-to-date guidance as we possibly can regarding the CARES Act and some of the regulatory changes and interpretations that are coming out daily and even hourly at times. But I do want to emphasize the fact that there are certainly going to be more changes and guidance yet to come, and our presentation attempts to go in detail with what we know now, and our intention is to continue to provide guidance to our clients and to the wider healthcare community as we learn more. This presentation really, our focus has been to provide on some of the more detailed guidance on what we view as being the key provisions in the CARES Act and related guidance for healthcare organizations. At this point, there's certainly been a number of emails and other postings on the internet in terms of brief summaries of each of the different provisions. What we really want to do here is focus on those areas that we think have the biggest impact on you, and to give as much detail as we can. This presentation really is meant to cover provisions that impact providers across the entire continuum of care. So I'm now going to jump into some of the healthcare specific provisions, and I'm going to start with covering some of the provisions around coverage and testing. Okay, so the first thing that we wanted to mention is that COVID-19 testing will be reimbursed to providers by, it's mandated by group health plans and health insurance issuers. And it's meant to be at an agreed upon rate with the payers, and if it's not agreed to with the payers, or if there hasn't been that discussion, then the mandated requirement is that the provider of the test actually publish the pricing for that test on the internet, so that it's publicly available. And that's actually the rate at which they will be, the provider will be reimbursed up until there may be further negotiations or discussions with the payers. In terms of preventative services with COVID-19, group health plans and health insurance issuers are required to cover all qualifying coronavirus preventative services. And that's been defined as any item or service meant to mitigate or immunize against the virus. It's unclear at this point what the word mitigate means there. I think that in general, it's meant to cover any services that are being provided to help to reduce the impact of COVID-19. I think there's clearly going to need to be more guidance that comes out on that. but it is important to keep in mind that those types of services should be reimbursed by group health plans and health insurance issuers. In terms of vaccine cost sharing, this eliminates the cost sharing for COVID-19 vaccine, which hopefully will come out, soon. And then in terms of hospitals, we wanted to point, everybody's attention who's involved with a hospital or health system to sections 3711 and 3715 of the CARES Act. In section 3711, acute care hospitals, have flexibility during the COVID-19 emergency period to transfer patients to alternative settings. There are some really important regulatory waivers limiting the 3-hour rule for inpatient rehab facilities and the 50% rule for long-term care facilities. And it pauses the long-term care hospital site-neutral payment methodology. In terms of section 3715, this allows state Medicaid programs to pay for home and community-based support services to reduce length of stay and free up beds in hospitals. It's become pretty clear that CMS is looking for whatever way they can to try to free up beds, and there's a lot of regulatory freedom that's being provided to hospitals to accomplish that, to move patients outside of the hospital as they experience a surge in COVID-19 patients. In terms of some of the reimbursement provisions, there are some very important ones here, and we're going to focus at the end on two in particular, which are the Medicare advanced payments and the $100 billion emergency fund. But in terms of the Medicare sequester, the Medicare sequester from 2013 reduced Medicare payments by roughly 2%, and that was set to expire, a few years from now. What the CARES Act provides for is that the period from May 1st to December 31st, 2020, that the payments to providers will be inclusive of that 2% that have been taken out for the Medicare sequester, which will boost payments in 2020, but the time for the sequester has been extended. The impact to providers has been extended, and actually it's an unclear area. It's mentioned that it will be that the sequester will be extended into the following year. It's unclear currently if that means that there will be 8 more months in that year, or if there will actually be an additional year of the Medicare sequester. And we'll be keeping our eyes on that. I think that would be a really punitive result. I don't think that will be the case, but it's still unclear. In terms of the 20% add-on hospital payment for seeing patients with primary or secondary diagnosis of COVID-19 during this emergency period, a couple things of note. Number one, it's a 20% add-on payment, and it does not apply to the professional component service provided by physicians. The other thing that actually was just announced today is that actually President Trump has just announced that the intention is for uninsured patients that are cared for in hospitals to the cost of taking care of those uninsured patients will be reimbursed to the hospitals. The funding for that is not clear at this point, but that pronouncement was just made. There's a DME payment reduction prevention under Section 3712. It prevents reduction in Medicare payments for DME through the emergency period. Similarly, for lab, the anticipated payment reduction for clinical diagnostic laboratory tests has been pushed a year. The FMAP increase is a really interesting one. It increases the federal medical assistance percentage by 6.2% for each qualified state and territory from January 1 through the end of the quarter in which the public health emergency ends. We've had a lot of questions and have had a lot of conversation internally around what that necessarily means for providers. There's nothing that indicates that the states are required to apply that additional 6.2% match from the federal government to actually issue an increase in reimbursement to providers, but that could be an outcome here. So on a state-by-state basis, it's important to see what the state is intending. You know, on the other hand, the states are incurring significant costs to their Medicaid programs, and it wouldn't be surprising if this did not directly lead to increased reimbursement. And then finally, in terms of the DISH payment reduction, that has sort of become the new doc fix bill issue, where we keep extending. The federal government keeps extending when the when DISH cuts may occur. They were scheduled to take place in the next couple months, and that's been delayed until the end of November. Okay, so we wanted to focus on the Medicare advance payments and the $100 billion emergency fund because there continues to be guidance that's been coming out. And frankly, with the Medicare advance payments, the initial fact sheet that came out from CMS really was unclear and left out a fair amount of information. So the way that the Medicare advance payments work is that for most providers, which is really providers other than acute care, inpatient hospitals, children's hospitals, and certain cancer hospitals, that up to 100% of the Medicare payment that provider has been receiving could be made available for a 3-month period up, all at once. The way that would work in terms of repayment is that beginning, so you receive the payment, you have 120 days before you have to pay back anything to CMS. And then you have up to 210 days from the date of the issuance of the advance payment to repay the balance. The more recent guidance that has come out has made a couple of things clear. Number one, the way that the payback will begin after 120 days is going to be a recoupment of costs that from services that would be provided by the provider between 120 and 210 days from the receipt of the advance payment. And then at the end of the 210 days, if there's any amount still outstanding, there's then a requirement to pay that back. And the way that will work, our understanding and the most recent guidance that's come out is that there will be a demand letter sent to the provider indicating the amount that's still outstanding. And then that provider will have 31 days to pay that amount back. The piece of information that was not included, but which has been made pretty clear from CMS in some phone calls and FAQs, is that if that amount is not paid, that outstanding amount at the 210 days, whatever's left outstanding, and after the 31 days from the demand letter, that a 10.25% interest rate will start to apply to that outstanding amount. So while this is obviously a great opportunity to increase immediate cash flow, and it's an interest-free loan for 210 days, it is absolutely critical that providers keep track of the amount of the recoupment and that they have the cash available to pay back to CMS when the 210 days ends. And we think this is particularly important for non-hospital providers, because that 3 months it will be measured from 120 days to 210 days after receipt of the advance payment. It's likely that volume may not be quite as robust as it was during the period of time that was measured for to receive the to measure the amount of the advance payment. So it's very likely that there will be amounts still outstanding after the 210 days, and it's just important to make sure that providers are being thoughtful about having that money available to issue back to CMS. And basically, the rules, the same rules apply to hospitals, but the hospitals, when they receive the advance payment, they can receive up to 6 months of Medicare reimbursement up front. And then they have up to a year to pay that back. And the repayment starts after 120 days as well. The difference there is that they have 8 months for the recoupment. So it's unlikely that there will be as much, or if any, in terms of outstanding payments at the end of that period of time for the hospitals. So wanted to make sure we got everybody up to speed on this program. And then the last provision that I'm going to speak to before I turn it over to my colleagues is the $100 billion Public Health and Social Services Fund. This is a fund that's been allocated to prevent, prepare for, and respond to coronavirus domestically or internationally for necessary expenses to reimburse through grants or other mechanisms eligible healthcare providers for healthcare-related expenses or lost revenues that are attributable to coronavirus. As that provision in that language makes clear, there's a lot of guidance that's going to be required here, but we do have a number of thoughts. First, by saying grants or other mechanisms, we believe that's an indication that this money will not be akin to a loan, that we believe it will be amounts that can be kept by those who receive the funds. In terms of the eligible providers, it's public entities, Medicare, Medicaid, enrolled suppliers and providers, and such for-profit and not-for-profit entities, not otherwise described. So it's quite broad, that provide diagnosis, testing, or care for individuals with possible or actual cases of COVID-19. So it's an extremely broad definition, and there are a lot of potential costs and lost revenue that could apply here. I think that what we have learned so far that we can provide guidance around is that there is some indication that the distribution of these funds may be in the 2/3 to 1/3 range, 2/3 to hospitals and 1/3 to other providers. That is from some guidance received from the American Hospital Association. That's their initial expectation. One of the big questions is, when is this money going to be provided, and what's going to be the allocation methodology to distribute among the different providers? And there has been some communication between the American Hospital Association and HHS requesting to distribute $25,000 per bed to the max, in most areas, and 30,000 per bed in hotspots, as a methodology of trying to get at least, in the $20 billion, $25 billion range out to providers as soon as possible. But we're still waiting to see if that's going to be the methodology that's used. The other thing that we just want to stress is that since there's not a lot of guidance in terms of the costs and lost revenues that are really covered under this provision, we think it's absolutely critical that you are keeping track of your direct costs, your indirect costs, and your lost revenue, attributable to preparing for or treating COVID-19 patients. It's better to capture costs now and to, as guidance comes out, to potentially take some of those costs off the table than to lose this opportunity to make sure that you're capturing as many costs as you can. Clearly, if you're not doing it, the provider down the street will. And so we think it's critical that you take it seriously to try to capture as many of your COVID-19 related costs as possible. If you can set up, cost centers to capture these costs on an ongoing basis, we think that's a good idea. So with that, I'm going to pass it over to my colleague, Kate Broderick, who's going to talk to some of the changes with telehealth, and which is an area that obviously providers are focusing on quite a bit right now.
Thanks, Aaron. So we wanted to spend a little bit of time focusing specifically on telehealth, both from a perspective of it's an obvious revenue source for folks who can't see patients in the clinic, as well as a path to reduce the spread of COVID. So we're going to go through regulatory changes, some reimbursement changes, but we want to spend some time on a specific program through the Federal Communications Commission. They were appropriated $200 million through the CARES Act. And they just issued guidance around their program yesterday. So we'll spend some time going over the specifics of that. In terms of telehealth, an immense number of regulations have been relaxed. HIPAA, specifically, the Office of Civil Rights will not be enforcing certain aspects of HIPAA. They have not provided a timeline as to when they will begin enforcing these certain aspects again. But what this will do is allow providers to communicate with patients via, platforms like FaceTime, Zoom, Skype, things that normally would have been prohibited by HIPAA. But in order to allow providers to stand up telehealth capabilities relatively quickly, they're allowing flexibility there. They do advise leaning towards things like Skype for Business or Microsoft Teams that already provide HIPAA-compliant video communications, as well as BAAs where possible. But so long as you're not using public communication platforms like Facebook Live, you are able to get some flexibility around things like FaceTime. Another key piece is around licensing. And I'm going to caution here that state and local laws do still apply. So it's absolutely critical to get with your counsel when you're thinking about how you want to stand up these types of programs. But what the waiver issued by Secretary Azar has allowed for is healthcare professionals that hold a license in the state in which they provide services, they no longer need to hold a license in that state, so long as they hold an equivalent license in another state. CMS has not yet issued guidance on how this is going to be implemented, but it should allow for the ability for providers to provide telehealth across state lines, which could be particularly important in areas like New York and DC, where patients may have traveled to or live in different states than where they're normally seen. Another piece on licensing I want to touch on with some of the regulations that were issued from CMS this week. They are allowing a broad number of providers to provide these services, mid-levels, licensed clinical social workers, providers. They have not specifically addressed physical, occupational, and speech therapists. Those providers were not included in these relaxed regulations. They are aware of the need and demand to provide these types of services remotely, and are currently reviewing how the CARES Act may allow for them to relax rules around providing those therapies via telehealth. A couple other changes to be aware of. Medicare has relaxed rules around new patients, so there's no longer a need for the patient to have seen their provider within 3 years in order to do a telehealth visit. They're also permitting audio-only visits, which is especially important for some patients that may not have a computer or a phone that has video capabilities. They're waiving requirements around nephrologists needing to do face-to-face visits periodically for CKD patients. Providers are able to recertify patients for hospice via telehealth. And there's also a provision in the CARES Act instructing HHS to issue additional guidance on the use of telecommunication systems for home care. Remote patient monitoring services would be an example of that. So we do expect there to be additional guidance from HHS around additional telehealth capabilities. Reimbursement changes, I'll go through some of the big ones here. CMS is going to be reimbursing for telehealth visits at the same rate as face-to-face visits. They've also expanded the number of codes that are reimbursable via telehealth. They've added 85 codes. This will include emergency department visits, which will allow providers, either because they're stuck at home, whether it's to reduce the spread of COVID because of PPE shortages, they can treat patients remotely for ED visits as well. Setting flexibility, the intention for Medicare is to allow these services to be furnished to beneficiaries in all areas, in all settings across the country. This will also allow flexibility for providers to furnish services from their homes. Medicare is also allowing healthcare providers the option to waive coinsurance and deductible requirements. And the last piece is CMS is issuing flexibility to Part D Medicare Advantage plans, allowing them to add services like telehealth that were not included in their original bid. So the FCC COVID-19 telehealth program, as I mentioned, this just came out yesterday. There was some buzz earlier this week that they were going to be coming out with a plan, but they did issue the rules around it yesterday. It does still need to be approved by the OMB, but once that happens, applications will be open. So this was a $200 million appropriation through the CARES Act, and it was fairly broad. It gave pretty wide range of flexibility to FCC to distribute this money as they saw fit. One thing to be aware of, this is specifically for nonprofit and public healthcare providers. So private physician practices, anyone for profit is not eligible for this money. They gave a pretty broad list of the providers that are eligible. In terms of the expenses, things to be aware of, it's for the purchase of telecommunications, information services, and connected devices. And the connected devices is an important piece to be aware of. So their intention there is, for example, a digital blood pressure cuff that would allow blood pressure readings to be automatically uploaded. It is not the intention that you would have an analog blood pressure cuff and the patient would enter their readings. So it has to be a connected device. The intention is to provide full funding for these services, but they don't anticipate awarding more than $1 million to a single applicant. Another piece to be aware of, providers are not going to be tied to the purchases that they outlined in their application. There's an intention for flexibility here. And applicants are also eligible to apply for more funds if they exhaust their initial grant. These funds are going to be awarded on a rolling basis. They are not going to be targeting any specific conditions, patient populations, geographic areas, but they are aiming to target the hardest hit areas. And two other pieces you should be aware of. These programs should directly aid the prevention of the pandemic spread. And they also need to be integral to patient care. So we'll be putting out more as we become aware of the application process. There's already pretty specific guidance on the FCC website. Another program through the FCC to be aware of is their Connected Care program. This isn't a new program. It was under a comment period. They've expedited it, so that will be going live as well. There's more stipulations around this program. It's specifically for veteran and low-income patients, whereas the COVID-19 telehealth program is a little bit broader. The last thing we want to touch on in telehealth are some programmatic considerations. As providers, you all are trying to stand things up quickly if you didn't have telehealth capabilities before. The first piece to be aware of, if you don't have a relationship with a teledoc or an Amwell, a service that specifically does telehealth, you're still able to stand up these capabilities using technologies that we all kind of have at our fingertips now. But you do need to be aware of cybersecurity and compliance. It's important to talk to counsel and to cybersecurity experts to understand the risk exposure, mitigation strategies, as well as state and local laws that are going to apply. Understanding your malpractice coverage, whether telehealth falls under it. I'm going to echo what Erin mentioned, bookkeeping. We don't know what types of funds may become available. So it's really important to carefully track costs and revenues associated with telehealth programming in a separate cost center. And as part of that, if you do choose to waive patient responsibility for Medicare patients under the new CMS relaxed regulations, you should be tracking any lost revenue associated there as well. Other things to consider, physical footprint. If you are seeing a lot of patients via telehealth and you've seen a precipitous drop in the clinic setting, is there an opportunity to consolidate space and reduce costs there? The same thing with staffing, unfortunately. And then things from a patient perspective to be aware of. Are your patients aware that telehealth is an option? How are you getting that out to them? How are you structuring your provider schedules to make sure that you're filling them as much as possible with both tele and face-to-face visits? And then also, of course, working with your commercial payers to understand what services they're going to be reimbursing for, what the rev cycle and documentation requirements are going to be to ensure that you're collecting. And then finally, privacy. All of these relaxed regulations, the intention is that they're done in good faith. And so providers do need to be making, their best effort to keep any PHI private. So a designated office, a designated exam room, something that will minimize the risk that any PHI is transmitted inappropriately. So with that, I'm going to hand it over to Blake to discuss the PPP and some of the loan provisions.
Thanks, Kate. Hi, everybody. Hope everybody is well during this time. So I'm going to go over for a couple of minutes the couple of popular loan programs for small businesses in particular. The first loan program is a Section 1102 of the CARES Act, the Paycheck Protection Program. I think if anybody on this webinar was looking to apply over the past 24 hours, they've quickly realized that the simplification of what everybody was saying is far from the truth. This has been a very fluid situation. Over the past 24 hours, there has been issues with the banks actually scaling back and not looking to accept loans at this time because of the uncertainty of how they're going to administer these loans. An interim final ruling was issued last night to make changes to the current act and how the loan proceeds calculation has been done. Big banks like Citibank, M&T, and Chase, as of last night, said they weren't accepting applications today. But I actually received an email as we're on from a client that they're accepting applications now. So I guess, first of all, I would just recommend that everybody reach out to their banks and see where they are at the process, but just be aware that this is still a fluid situation, and there is some parts of this program that's subject to interpretation and could be subject to change. So let me just go into the overview and how this loan works. So it's a small business loan. It's 500 less. How that's calculated is it's based on average number of employees per pay period. And the information that the banks are looking at right now is for the calendar year 2019. This loan requires no collateral, no personal guarantee. This is really a good faith certification that you're using your best judgment to provide the information that they're looking for. On how the loan size is determined, the max loan is equal to the lower of 250% of your average monthly payroll costs, which we'll talk about, or $10 million. Payroll costs are defined as compensation to employees, not to exceed $100,000 or monthly of $8,333 per month. It also includes group health care coverage, including insurance premiums, net of employee contributions, retirement plan benefits. What this does not include, which was an adjustment to the in the ruling last night, was that independent contractors are no longer included in the payroll cost calculation for a small business. And the reason why is because independent contractors are able to apply for the PPP themselves. So that's the reason why they're no longer included in the calculation for a small business. To be eligible for a loan forgiveness, the moment you get the loan proceeds, you have 8 weeks from the date of that loan origination to use the funds on employee compensation, health benefits, rent and utility payments, and interest payments on mortgages and other debt obligations. Okay, at least 75% of the loan proceeds needs to be used on in that 8-week period to be eligible for full loan forgiveness. The portion of the loan that will be forgiven is based on a ratio of your full-time equivalent employee headcount during that 8-week period compared to a headcount during the period of February 15th, 2019 through June 30th of 2019. It needs to be comparable to that time period. Employees that you retain and bring back to the workforce, you need to bring them back to at least 75% of their original salary. If there's declines in headcounts between February 15th of 2020 through April 26th of 2020, this won't trigger a reduction in loan forgiveness, assuming that you reverse this decline and return it to the right levels by June 30th of 2020. Once loan forgiveness is calculated, that number will not be included in the business's taxable income. The interest rate of the PPP is 1%. That was another change in the interim ruling from last night. It was originally 0.5%. The maturity date of the PPP loan is 2 years from the origination date. There's a 6-month deferral to begin making payments. These loans are administered through the banks under the SBA 7A loan program. And like I had mentioned before, there's an interim final rule which hasn't been signed. It is still subject to change. There's still a lot of holes that I think the whole world is trying to interpret to see if certain employers, self-employed individuals, partners in a partnership, where they fit in, because it seems a little vague in certain aspects. And like I said, I would reach out to your bank to confirm whether or not the application process has opened yet. Kate, can you go to the next slide? Great, thank you. The next loan I'm going to talk about is the economic injury disaster loan. This has been a loan that's been available for a while now. This is more of a general SBA loan, still for qualified small businesses under 500 employees. You could receive loan proceeds of $2 million for working capital purposes. This is just more of a general working capital loan. The SBA determines the exact amount a business can borrow based on cash flow projections and demonstrated need. This is a lot different than the application process for the PPP. It's a very in-depth loan application process. A lot of information is going to be required. If it's over $25,000, they require capital, require collateral. Personal guarantees are required for loans over $200,000. Like I said, it can be used for working capital, accounts payable, inventory, equipment, machinery purchases, real estate payments, and other operating expenses. This program is not eligible for loan forgiveness. The interest rate currently on this is 3.75%, and the borrower can defer principal and interest for the first 11 months of the loan. These loans are administered directly through the SBA website. What some small business owners may have seen is that there's also a short form application with the EIDL as it relates to this $10,000 advanced grant. So just for full clarity, this is a separate loan application from the full EIDL loan. This is just a $10,000 grant to get some money in the business's pockets quick. I think it usually takes around 3 days. But you're also here making a good faith certification that you're at a minimum going to apply for either the EIDL or the PPP loan. You can apply for both the EIDL and the PPP, but if you do apply and get funds for both programs, the PPP is specifically used for those payroll and benefit costs. If you also receive funds for the EIDL, you cannot use those funds for those costs. And if you do apply for the EIDL loan and or grant, those amounts get adjusted to the PPP. So the loan amount gets added to your PPP number, not to exceed $10 million, and the $10,000 grant is subtracted from the amount of PPP proceeds that you could receive. Now I'm going to pass it over to Ron for the tax provisions of the CARES Act.
Thank you, Blake. Like the loan provisions, these tax provisions, while applicable to all taxpayers, are certainly going to have implications throughout the healthcare spectrum. The first provision that is available is a refundable tax credit, and it's called the Employee Retention Credit. It's available to businesses of all sizes, and they will qualify for the credit if a business is either partially or totally suspended by a governmental COVID-19 order, or if their gross receipts have dropped by more than 50% in each of the remaining quarters for 2020 compared to the matching quarter for 2019. If a business has less than 100 employees, this credit will apply to all wages that are paid. If a business has more than 100 employees, the credit will only apply for employees who are unable to work because of governmental orders or shutdowns. What the issue for the more than 100 employers in this scenario is with medical services being qualified services that can continue during shutdowns. Many of the wages that are being paid to doctors, nurses, and other patient-facing employees may not be eligible for coverage by this credit. The credit is based on qualified wages up to 50% of wages paid, with a maximum of $10,000 of wages per employee, meaning the credit is $5,000 maximum per employee. The credit is granted through a reduction in otherwise payable federal payroll taxes, meaning Social Security and Medicare taxes, and to the extent that the credit that is available on a quarterly basis exceeds the total amount of taxes otherwise payable by the employer. The IRS has just released a form within the last 72 hours, actually, that currently is still in draft form, but it's a Form 7200, which is a document that can be used to request a rapid refund of amounts due for the credit that are in excess of taxes otherwise payable. You should keep in mind that this credit cannot be used if you're filing for a loan under the PPP process that Blake recently described. The next generally available credit to, again, all employers is an ability to delay the payment of employer payroll taxes. This will allow employers to defer portions of their FICA and Medicare taxes that are due on payroll earned by employees for the period March 27th through December 31st, 2020. Those taxes are completely deferrable, with 50% of them payable by December 31, 2021, and the remaining 50% payable by December 31, 2022. These are deferrable without interest and without penalty. And again, an important caveat that this deferral of, or this delay of payment of taxes is not available if an employer is going to have a loan forgiven under the PPP loan provisions. If Kate, if we could have the next slide, please. Some of the other generally available provisions relating to for-profit businesses is, one of them relates to a revision to the 2017 Tax Act, which eliminated the ability to carry back net operating losses, and it also limited on a go-forward basis the ability to use net operating losses against only 80% of taxable income. For years beginning in 2018 and 2019 and 2020, the net operating loss rule, carryback rules, have been suspended, and individuals and businesses that have net operating losses for years arising after 2017 will be able to carry back these losses 5 years. One minor item is that if you are in this situation and have a small loss, and the determination is that you really are not interested in carrying that loss back, there is a 120-day window which began on March 27th that would require you to file a waiver with the Internal Revenue Service explaining that you do not wish to avail yourself of this newly introduced carryback period. For flow-through businesses, this next provision, which was the excess business loss provision that came in with the 2017 Tax Act, that beginning in 2018, if an individual with a business loss in excess of $500,000 existed, that loss in excess of $500,000 could not be carried back. The excess loss was converted to a net operating loss and was carried forward along with other net operating losses. For the years 2018 and 2019, as well as 2020, this provision has been suspended so that when individuals have otherwise usable losses on businesses, they would be able to deduct them fully in either their 2018, 2019, or 2020 returns. And again, to the extent that these losses may create net operating losses, including for the year for returns that have already been filed, the net operating losses can be carried back. Briefly, the Section 2306 modification was a provision in the 2017 Tax Act that limited a business's ability to use interest expense if the business was a flow-through business. The use of interest was limited to an amount that was referred to as 30% of adjusted taxable income. It's been increased to 50% of adjusted taxable income for the years 2019 and 2020. The last item, which is of significant use, is the qualified improvement property technical correction. When the 2017 law was enacted, there was an error in drafting that turned qualified improvement property, which is primarily for this group, leasehold improvement property, turned it from 15-year property to 39-year property. And the biggest difference, besides the increase in depreciation lives from 15-year to 39-year, is 15-year property was eligible under the bonus depreciation rules for immediate write-off. The CARES Act retroactively changed the rules for property placed in service after September 27th, 2017 to allow qualified improvement property, which again, for these listeners is primarily leasehold improvement property, to be immediately deducted. So there are opportunities to amend returns that have been filed and to revisit treatment in the 2019 year returns. At this point, I will turn things back to Aaron for questions and answers.
Okay, thank you very much. We're going to try to run through as many of the questions as we can that we have time for, and I'm going to run through them sort of in order of the provisions that we covered in the presentation. So the first question that we received was, is the FMAP 6.2% increase a raw or absolute increase, or is it based upon the percentage of the total Medicaid funds that were being that were the federal proportion? So the answer is that it based upon the FAQs and what we've seen is that it's based on the raw or absolute amount. So if you are a state that for every dollar that Medicaid in the state spends, that basically they get a $1 match from the federal government, it's now going to go up. That $1 is going to go up by the 50% is going to go up to 56.2%. The big question is going to be whether that ends up going to the providers or not. But it is supposed to be an actual 6.2% increase in the match. The next question is, with the Medicare advance payments, do those apply to ASCs? And the answer it appears to be yes, as long as that ASC has been seeing Medicare patients. There are specialty surgery centers out there that do not take Medicare patients. Obviously, this wouldn't apply to them. In terms of the payment timeline for the max, with the Medicare advance payments, there was a question on that, just to go through that timeline once again. Again, for non-hospital providers and suppliers, from the date of the receipt of the advance payment, you then have 120 days where you are not required to repay at all. Then from 120 days to 210 days, the amounts that the advance payment amount would then be recouped out of payments that Medicare would have made for services provided from 120 days to 210 days. At the end of the 210 days, there will be a demand letter issued by CMS indicating the remaining amount that has not been repaid to CMS. And then there is supposed to be a 31-day period before the payment is due, and if it's not paid by then, that you will end up having 10.25% interest applied on that outstanding amount. I do want to mention one thing. We have actually called some of the MACs, and we've looked on their websites and tried to make sure everybody is looking at this the same way. And we're actually finding that there's even disparity in terms of how the MACs, the guidance that they're giving. But it's from CMS, the guidance is that it's 7 months to be able to pay back the full amount that is due, or 210 days. So the next question that we received was on the telehealth section. So Kate, has physical therapy been approved for e-visits through Medicare? Kate, you may be on mute.
Can you hear me now?
Yes.
Okay, sorry about that. E-visits are permitted. What CMS has not made a move to do is to deem PTs, OTs, et cetera, as telehealth providers, to provide them with that additional flexibility that has been afforded to the other kind of provider classes.
Okay. So moving on to some of the questions about the loans, and I do want to mention to everybody that's on the webinar, for those questions that we were not able to respond to, we will be we'll make sure that we get those answers back to the individuals that are requesting them. If there are enough sort of outstanding, we may end up sending out sort of a FAQ list and responses to the attendees. So the next question is, can you apply for the $10,000 through the EIDL through different companies with the same owner, Blake?
So assuming that they're all under different tax ID numbers and different business entities, I don't see there being an issue applying separately for any of those.
Okay, great. And then let's see, next question. Also, Blake, in terms of, you mentioned recipients have 8 weeks, from the receipt of the PPP funds to disperse for allowable expenses. So can a company who qualifies for the loan today wait until the end of the PPP program window, so say June 30th, to receive the funds from the bank, and subsequently have 8 weeks from that point, to disperse for allowable expenses? Is this possible? And do you think there's a risk of the PPP program running out of funds?
Big risk. Yeah. I think they hit it right on the head. We haven't received any guidance that if and when you get approved for the loan, that the funds aren't, that they're going to come. We're taking the position that they're going to come immediately. We haven't heard anything otherwise, that when you get approved, that you can let them know when you want the funds. So, you have until June 30th of 2020 to apply for this loan, but it's not advisable to tell anybody to wait, any later than they have to apply for this loan, because there's only so much money to go around. There's going to be millions of small businesses waiting online to get this.
Okay, well, great. Everybody, really appreciate the time to listen in. These are really important provisions that are impacting everybody. and we wanted to try to get as much guidance and interpretation out as we could. We wish you all very well. This is a remarkably challenging time, particularly for healthcare providers. And hopefully this has been helpful. If you have any other questions, you can feel free to direct those to us individually, and we'll make sure to get back to you. Thanks everybody, and I hope everybody has a nice weekend.